to start with, I'm Venu. I'm one of the second years. Today we'll talk about delirium. We have had a very interactive and interesting lecture by Dr. Leitwig. She covered most of the management part for delirium, and we talked a lot about dementia, but I think it's also like demented patients are at high risk for delirium. I'll try to focus mostly on what type of orders, and we as resident physicians, especially interns, when you get paged, how you respond to those pagers. So fine, I won't then go to the next slide. So this is what I initially planned on talking about, but I will minimize, of course, because we have had an extensive and very informative lecture by Dr. Leitwig. So delirium, to define, it's an acute change in mental capabilities of a patient. Specifically, you'll hear the caregiver say that, this patient does not look like himself. He does not look like what he was before. So it's usually most of the history comes from the family members. And also if the patient is in the hospital for a few days now, the nurse who has been taking care of him, they are the ones who will first catch these symptoms of the patients. They say like, he's well, when we go to the types of delirium, I'll tell you like how the symptoms would usually look. But then these complaints, like, these mental changes in a patient are usually reversible, but they can last for a few hours to weeks to, it has a very long-term residual effects as well. The most prominent and feature I would say is like waxing and waning level of consciousness. That is like one of the most distinguishing features when it comes to dementia. We'll also talk about it a little later. Well, there are three main types of dementia. Most of the times, we get pages from nurses about patients being very aggressive, they're agitated, confused, they're pulling their lines, tubes. Sometimes they're harmful to them. So it's not only like in the medical management, but they are trying to hurt themselves and also the other staff that are taking care of them. This is one spectrum which we are most commonly exposed to in a hospital setting. And then other type is hypoactive, which is often overlooked. Patients, it's nighttime dementia, like the other name for it is also sundowning, and it tends to happen during evening times when patients are more sleepy, lethargic. And the normal thing is also that, right? Like when it's evening, we tend to be more sleepy and, not as responsive as we are during the daytime. So it's very, very easy to kind of overlook these kind of symptoms, and we underdiagnose patients with delirium when they're present with these symptoms. I think Dr. Leitwig has also mentioned how it's easily missed. And then there's the mixed type where they can be alternating between these two types of delirium. I think we touched this topic a little bit about what are the risk factors for delirium. Like she said, dementia, of course, is one of the major big risk factors. But when coming to, again, it's divided into three major things, like environmental risk factors. Just being in a hospital is a big risk factor for patients ending up with delirium. It's especially for older patients, right? They come from their home, they come from adult foster care. It's a very controlled setting. They know where things are, they can look at the wall clock. Some rooms we do not have like times. And there are rooms where, I think there are a lot of good rooms where there's enough sunlight, but the blinds are closed. They do not know if it's raining, if it's like, if it's the daytime or nighttime. And a lot of the patients have vitals checked during the night and they wake up so many times. So that orientation is all lost. So being in the beep sounds from the cell, I'm sure when we are taking this history, like talking to patients, we have to silent it so many times, like reset the drip line multiple times. So those are all like some annoying noises and, disturbance the patients can have while they're admitted in the hospital. So those all come under the environmental factors. Patient characteristics, age, a big risk factor. And then Dr. Leitwig was mentioning about how, like they do not bring their hearing aids from their home. They cannot it's just basic functioning of human beings. We want to be able to see, communicate, hear, and like it's mutual communication. So when these all are interrupted, it's more prone for these patients to kind of get confused. Medications, we did talk about that. And the whole big case we discussed about how post-op situation can be a big problem for a risk factor for delirium. Coming to medical conditions, again, dementia, post-op burns, and then simple problems like severe constipation in elderly patients and multiple medical issues, including infections, as simple as UTI, pneumonias. These are all the most common infectious risk factors for patients ending up being confused and agitated. There's a very long list of medications which can increase the susceptibility of elderly patients to being agitated, confused. But I think most important ones would be opioids, benzodiazepines, anticholinergics, and steroids. I remember I had a patient who was admitted with for COPD exacerbation. Obviously, we have a lot of COPD exacerbations, give them steroids, irritable jitteriness in the night. And then sometimes, obviously when we are giving them oxygen saturation more than what is needed, like the 88 to 92%, and then they have CO2 retention. So it's both steroids on top of them being carbon dioxide narcosis, which will precipitate all these symptoms again. Mechanism, it's still not understood. It's very unclear, but then overall, a lot of research is being suggested saying that there is overall an imbalance of the neurotransmitters in the system, and also defects in the neuronal depolarization. Cytokines have also been, there's still ongoing research about cytokines being involved in the mechanism for the cytokines linked to neurotransmitter transport along the neuronal membrane, which is kind of affecting the normal processing of the brain function. Differential diagnosis, again, I think it's a big deal that we differentiate between dementia and delirium. Dementia is a chronic problem where you will also see in like clinic setup. It tends to not have a waxing and waning course. It's a chronic progressive decline in a patient's mental capacity. While compared to delirium, it is usually fluctuating levels. You have those waxing and waning periods. It's very important to differentiate patients who have underlying psychotic disorders. I remember a very young patient who was in the ICU, was agitated to a point that he coded. So yes. So delirium causing, like he was intubated. He came in with, he has underlying psychiatric disorders, substance abuse disorders. He was intubated because he was all agitated for airway protection. And then he was on a lot of drips. After about 3 days, we tried extubating him, but he was agitated to the point that he wrapped his hands against his throat. He became cyanotic and coded in like the next 10 minutes. So we had security come in and he was reintubated. So, psychotic disorders are also a big risk for patients ending up in delirium. Going to next slide, prevention, we discussed a lot. Frequent reorientation, again, it's a multi-team approach to prevention of delirium in patients. Big role, I would say, will be with the nursing staff, of course, just like patients who have forgotten their high hearing aids and, they want their glasses, make sure like they have all those equipment with them. Frequent reorientation, tell them where they are, what's going on, and time, place, person orientation, of course. And if not needed, we should let the nurses know it's okay to not check their vitals, because sometimes we have vital checks every 2 hours, every 4 hours per shift, those kind of things. So avoid and minimize as much as possible if you can. Pharmacy, I think this is mostly, I have seen at least here in our hospital, they play a big role in ICU setting more than like on the floors. We have like multi-team rounds. So if there's any like potential medications that are precipitating these, they kind of give us a warning and say that if we could just avoid that polypharmacy situation, just identify the medications that can precipitate these and discontinuing them again if possible. Role of doctors would be like to supervise, and our main role would be identify the underlying cause and treat and correct it, and it's mostly reversible, so try and address it as soon as we can.
One comment sort of is that it's also important to not underestimate family. So you can always, at least pre-COVID as well, you could always have family members stay with the patients, and even now there are exceptions. So if someone has moderate to severe dementia, bringing them into the hospital is going to make them even more altered anyways. And if there's a family member they feel comfortable with, you can talk to the nurse manager on the floor and make a request for an exception.
Absolutely. I think we had that done for some patients.
Saves us having to, which you would talk about.
Yeah, I think that would be one of the major help we could get from the nursing staff. If we could just have one nurse take care of that particular person. I know like everyone has shifts, but then if we can have them just stick to that one patient. They are more acquainted with them. And also, like Maham said, if it was not the COVID situation, we can always have family come in so that they feel more like more comfortable with having familiar people around. Um, so this is what I wanted to mostly talk about, like delirium in inpatient setting, where interns and of course all of our residents will be facing. It's a very, very, very common problem, especially in patients more than 65 years old. About 30% who are more than 65 years old, and at least 50 to 70% of patients who are more than 70 years old do have delirium. Even if you have not seen a lot, it's probably missed. We do not diagnose them. It's much underlooked, and we underdiagnose this problem in a hospital setting. Although you keep getting pages, as many overall survey shows that it's a very underdiagnosed problem. And what if there's delirium and you treat the underlying condition, patient gets better? Why do we need to worry about it, right? I mean, you just correct the problem that they came in with, and sometimes they get better and sometimes don't. But the most important thing is why we need to catch this early. It has shown to have a permanent damage to the cognitive capacities of a patient, and it also affects the overall morbidity and mortality. It doesn't matter what disease they came in with. Just having these fluctuations in their consciousness and cognitive capacities while they're hospitalized, as such, has a significant effect on the morbidity and mortality of these patients. So it's very important that you catch these early and try to prevent initially, but if you cannot, like, catch early and treat it. This is how a page would normally look. I think when you get, sometimes it's just a number, honestly. Sometimes it's just a number that you have to call back, so just call them. And when a nurse tells you that, they mostly would tell, like, the patient does not look like themselves, we are a little bit concerned, then you want to obviously obtain more history. What would be the normal baseline? Do a quick chart review of the notes, like what is the baseline mentation if he's coming from an adult foster care, alert oriented times 2, 3, is how far is he deviated from the baseline, what are the underlying medical conditions. You go at bedside, assess the patient, see if he has any fevers. You want to rule out all the basic stuff. Has he had a fall? Maybe he was just going to use the restroom, came back to his bed, fell. Did he hit his head? This history would more streamline what orders we want to put in, and further management would obviously depend on our history and examination. Obviously, review medications. I like that MMSC, which Dr. Leitzel pulled out. So I haven't done that much, but at least like a brief, quick neurological examination, orientation to time, person, place, see what is the baseline mentation, and see if the patient is interacting with you. Is there a two-way communication, or is he just drowsy, lethargic, or combative? Again, the management. The most important part is to try and identify the underlying cause of the problem and fix it. But before that, sometimes you do not have the time to do it, and it's important to control the symptoms of these patients. There's different medications. We talked about Haldol. This is a algorithm I pulled out from UpToDate. So these things go hand in hand. You simultaneously do a review of medications, history, physical examination. Yeah, so okay, it's okay. I think this is all what we discussed. You have to do things simultaneously. You want to get the history, do a physical examination. On top of that, you do a quick chart review to see if this patient, what he was being treated with during the morning shift. Like, was there a new medication that was started this morning? Was he dehydrated? If you need to repeat a CBC, like the common blood work again. And if he's spiking new onset fevers, you do the whole infectious workup. And then if, meanwhile, while you're trying to identify these causes, that's when the medications, restraints, and all these would come into picture. Again, symptomatic management, we discussed about Haldol, Zyprexa, like we discussed. Haldol has a lot of research done, and that's why and it's also easily available in our hospital. So that is one of our go-to medications. So you start with 0.5 milligrams and go to 1 milligram every 4 hours as needed. Sometimes we also do a one-time dose, but that is not recommended. Usually these patients have a waxing and waning course. So although a one-time dose looks like they have fixed the problem, probably they're just going into it the next day and you're not on night shift. It'll be some other person who will be taking care of that patient. So just put a PRN order and document in the notes. So we'll see like how many times they have got it every day and if it needs to be scheduled. So Haldol is one of our go-to medications. The next most studied medication is Risperdal, and side effect profile, like we discussed before, Risperdal is better over Haldol is my understanding. But there are two small studies on Risperdal and olanzapine, which were both compared, and they said like similar effects. So I think I have to read a little bit more about like which medication is better over the other, but as interns, and I think in our hospital, especially, I have seen Haldol being used a lot, and also Risperdal. Benzos is our last one. No benzos. Studies have said that no benzos, but there will be certain situations where we cannot avoid them. And it's okay to use them, but make sure it's not like repeated. And then they start withdrawing from those benzos when they're not being getting that.
Broadly classified into one is like confusion, restlessness, patient doesn't know what he's doing, he's lying on the bed, is a fall risk. And one is patient is aggressive, he's getting more violent, he's getting, and you really need to calm the patient down. So if he's more restless, just, doesn't know what he is going through, and then the patient keeps on getting on the bed, it's a problem for the nurses. First is non-pharmacological orientation. If that doesn't work, we go with the medications. For these patients who are just restless and all, I don't slap them with Haldol and Risperidone. These are very strong medications, and if they already have some dementia, the next day would be very difficult. We usually give a low dose Ifexa. There are two IM injections, so if the patient is not willing to take orally, we give low dose Ifexa 2.5. QTC interval is least affected by the Ifexa, so suppose 70 kg, so safely give it. Seroquel is another, it's an oral medication. So most of the time, if you need an IM source, that Ifexa is going to give. For patients who are very agitated, very aggressive or maybe violent, we use Haldol and Risperidone. There is also
Oh, the cocktail for Benadryl, Haldol. I think like there's like different cocktails like based on where the patient is based at, right? Like in ER and in ICU and in on floor, there's like different cocktails also attending space. So the one thing I wanted to tell here is about benzodiazepines. They are not recommended at all for patients with delirium unless it's due to alcohol withdrawal or something like that. But otherwise, no benzos. I know we do it sometimes, but that's not the right way. So we did talk about haloperidol, and not only like Haldol, when patients are on these antipsychotics, QT prolongation is a big problem. So make sure they have a baseline EKG. And then it would be preferred for them to be on telemetry if they've been requiring more and more almost every day. Like if they're requiring these antipsychotics, make sure like they're on telemetry. You could also check EKGs daily, depending on how much of the antipsychotics they're getting. And there is a recommendation where they want cardiology on board, which I think they wouldn't be happy. But then if the, yeah, for patients who, yeah, and if QTC is more than 450 or more than 25% above baseline and antipsychotics are unavoidable, that's when they're recommending like a cardiology consult. But at least as, like internal medicine doctors, we should at least get an EKG, see what's going on. And then if they have any, just QTC prolongation, sometimes it's not actually indicated, but you can just let them know. And if they have any of those charts, I read them, like, those, and also like other electrolyte abnormalities coexisting, which would make them more prone to develop these arrhythmias, then it would be ideal to just quickly touch base with them and go from there. Again, benzodiazepines, no benzodiazepines. It has a very limited role. Lots of studies have been done. Unless alcohol withdrawal or when antipsychotic medications cannot be given, only then can we do some benzodiazepines. We usually start Haldol at 0.5 or 1 milligram. 1 milligram to 2 milligrams is what is recommended, and you dose it every 4 hours as needed. But you can also start it as low as 50% as recommended, like 0.5 milligrams for patients who are older and at increased risk for delirium. When you notice that patients are required, like as needed medications are being given regularly because they're so agitated, always schedule these medications. Restraints. Again, you'll be paged multiple times for renewal of restraints, but I don't think, usually nurses take over and they place like, they usually decide and also like touch base with you when they want to put patients on restraints. But I think as physicians, it's really important. Nobody would like to be restrained, right? Like anyways, it's our basic fundamental right. We want to be free, and you don't like anybody restraining you, and it's a big ethical issue. Make sure like the restraints are really required, and only then put the patients on restraints. Always document why you are doing it. I'll show the next few slides will show what are the different types of restraints we have got. Non-behavioral restraints is mostly like when the patients are pulling at their lines, tubes interfering with medication. Some patients, they usually have tubes, some they are also tubed. We don't want them to be pulling them out. Obviously, it's imminent self-harm. Sometimes very agitated patients, they're yelling, they're pushing you. So it's also injury to the caregivers. As physicians, it's our responsibility to make sure the patients are safe, and also the nursing staff and other staff for taking care. Also ourselves, protect yourself too. I know 1 or 2 residents who got hit by patients, so take care of yourself too.
You say that very fondly, like you're smiling as you say it.
It was for
In case someone didn't know.
In case someone didn't know. So these are like the when you put the restraint orders, you have the oh, she's put in the spotlight. Sorry, Farah. Yes. Coming to restraints, the basic thing is put all the, when you put the orders, there is some check boxes which you can click, and one of them says like 4 side rails. This is what it looks like. The hospital beds have these restraints on the sides. And then this is the soft mitts, when patients are just like, they're pulling at lines, but not a big threat for like self-harm or injury to others. That's when you use these mitts. These are how soft restraints look like. And these are the 4-point soft or hard restraints. That means like you're restraining both the upper and the lower extremities. When you type in restraints, when you go to the manage orders tab, by now some of you might have already been using it a lot for on-prem. So when you go to restraints, this is all that will pop up. And you select non-violent restraints, violent. The next slide should be able to show that. So here's what is the 4 side rails up, the first picture that was on the previous slide. And then an enclosure bed, I haven't seen one here. Enclosure bed, yeah. Mid restraints is what we have seen in the other picture, this one. And then most of them are on soft restraints. You can just put them, if they're agitated, moving only their upper extremities, just limiting their upper extremities is fine. You don't have to do all the 4 at the same time. Yeah, even just one hand is fine. Yeah. Yeah, that's right. Yeah, only just one hand. Yeah. And always like check, put like continuous for 1 day. These restraints, you have to renew them every 24 hours. And click on whatever restraint you want to place. And also this one where you want to say they're interfering with medical treatment. And then it's the chemical restraints is nothing, but all these medications will auto-populate when you check, when you select chemical restraints, antipsychotics. I think it also includes Benadryl. I had to sign this order in for me to be able to see what medications come in, and I didn't want to do that to a patient who was admitted, so I didn't pull up what all are the medications. I saw that for one patient who was having obviously like underlying psychiatric disorder. I was on night float and we selected chemical restraints, and I'm not sure if those Benadryl, benzos, antipsychotics were already there, but I remember like my senior at that time was telling me like the medications auto-populate too. It's a order set or something like that. Oh, for these things, it's not necessary. Okay, makes sense. Okay. Mm-hmm. Yeah, that makes sense. Yeah, physical hold. I saw Majid talking about it. That's when you want your, like, sometimes like security or even the other nursing staff to. Mm-hmm.
Physical hold?
Yeah. Not someone in restraints. I'm like, that's what the restraints order. I'm like, why do you want to take over? And I'm like, but that's probably what we're referring to.
So that I was talking about that patient in ICU who coded after he was extubated. We placed that physical hold order. I mean, even before we placed, safety was a concern, so they just called security. And the recommendation is one security person for each limb, and if possible, one more too, like just put like on the belly. Yeah. Yeah, this is what is physical hold. What is this? It's the same one, but then when you put restraints order, always begin with like 1 hour. You wouldn't want to like do things like this to your patients. Try to avoid, but there are situations unavoidable, but you can do. And these you have to renew them every 4 hours. The nurses are on top of it. They call you and they'll ask you to renew them anyway. So yeah. Documentation, which is the big part. So when you go to the tab, the downward pointing arrow below the wrench, you go all the way down and then you see the restraints. When you click on it, it brings you to this tab, and then you click on the new reading here, and then all these things pop up. You can always choose other and type what you want, like if you want to document what has happened. But these are like some quick selections that you can make. Once you select them, they come like this, and then you just click on close, and that's completion of your documentation. Ethical considerations, very underrated, but we already touched based a little bit about this. Nobody would like to be restrained. It's a basic fundamental right. Use restraints only and only when needed. We do have a lot of patients who would definitely need them, and don't hesitate to use them if the patients really need them. And after they have been placed on restraints, it's very important that you review the need for continuing those restraints periodically, like in the day shift. When the night shift is done, the morning team is coming. When you go see your patient first thing in the morning, see if they need it like during the day as well. If they don't, just remove it, and then the night people can do it if he needs it again. Code bird. Usually the nurses call, but if you happen to be the first person to know this, it's behavioral emergency response team. It is a team of doctors, nursing staff, and the security personnel who will try to limit any harm that can happen in delirious patients, harm to themselves and also harm to the caregivers. So what they say is one team leader, which will be us, who will kind of we are we're always in the background, but doing the major stuff like reviewing what can be done to address this problem medically. And then there will be a nursing staff who will be there to give medications, just like a code blue, but it's not that bad, like that severe. And then one staff member who will document, like the ICU patient who we had. It's important to document because he coded. So one person who will document, but it's not always needed. And then, like we discussed, at least four security guards to restrain the four extremities, and one member to restrain the whole body. I tried to wrap it up fast. Any questions?
So I don't want to take too much time, but this is from like talk about really scenarios someone wants to share. I know it feels very deep, but I want to encourage the second year specific and share an experience you have. So like to give the interns an example of yes, this is actually what happened and how you address it.
My scenario is phenomenal.
want to put them in a train or
Yes.
do any medications unless absolutely necessary. So rehabilitation, not even steroids, but just go by that time trying to get their wife on the phone. And the other experience was more recently, which is actually continuing on to this term. There's a patient that was already in soft and used restraint, but he was still able to pull as effective and without restraint.
Wow.
Regardless of that. So it's important to assess that site to make sure it's tight enough for the
Yeah. Yeah, I think that's a very important point when you're planning on discharging your patients, especially when you're on nights.
Rule of thumb on nights, whenever you go to the bedside and see a patient, talk to them, is a lot of, like, I've been to a lot of these meetings where they go back and discuss if something happens, like an event happens to the patient, and if you don't document anything, whatever the nurse have documented, or the staff, good or bad thing, whatever people have documented is what people depend on. So just like a habit, whenever you go see them, just put a subjective, objective assessment plan. This is what we're gonna do. I know it's annoying sometimes if you're very busy overnight, but just a 2-minute briefing to make sure to document that you actually evaluated the patient at that time as soon as we can. It's very important, and you'll see that whenever like something happens, sometimes they invite people. I know anyone went the other day to this meeting about what it has nothing to do with the program, but they would ask us, they would invite us to attend this meeting, and you would see how everything in the chart is the only thing that matters. Nothing else matters. It doesn't matter. If you don't document it, it does not happen.
And also one point, I think I've seen a day shift people, they usually mention in the note, please avoid benzos. Make sure you quickly review the note and don't give benzos if they said no.
And sign out to the next team.
Yeah, sign out.